Welcome to Chiropractic Science, where you get to hear interviews with leading chiropractic researchers from around the world. Hear about chiropractic research from the authors in plain English, not through the media nor a middleman. My name is Dr. Dean Smith, and I am the host of Chiropractic Science. I'm a senior clinical faculty member in the Department of Kinesiology and Health at Miami University, and I'm also a practicing chiropractor in Eaton, Ohio. My research interests relate to understanding how chiropractic affects motor control and human performance. Before we get into the interview with Dr. Carlo Ammendolia, I wanted to thank all of you who have subscribed to Chiropractic Science, and I am especially appreciative to all of you who have contributed 5-star reviews on iTunes. iTunes reviews really help others find out about chiropractic science. So if you like the show, please take a second and write a review. It will support chiropractors everywhere. I'd like to share a review on iTunes from Dr. Paul O., DCMPH, who says, quote, Dr. Smith, you bring insights from contemporary researchers from around the world. Being active in technique development, research, and practice, I am re-inspired by learning of developments from the motor control and neurophysiological disciplines. I am reminded of the references and research personalities my mentor, the late Joe Keating, would report, and that these podcasts continue in that same spirit. Keep up the great work. Unquote. Well, thanks, Dr. Paul, for your review. I look forward to sharing your clever and flattering iTunes review in a future podcast. Please consider making a contribution to Chiropractic Science to keep these podcasts going. You can do so on our website by making a donation or purchasing the evidence-based patient education slides presentation. We are also on social media, including Facebook and Instagram, so please connect with us there. All right, on to the podcast. Well, let's get on to the interview with Dr. Carlo Ammendolia. Dr. Carlo Ammendolia is the director of the Spine Clinic and the Spinal Stenosis Program at the Rebecca MacDonald Centre for Arthritis and Autoimmune Diseases at Mount Sinai Hospital. He received his MSc degree in Clinical Epidemiology and Healthcare Research and his PhD in Clinical Evaluative Sciences from the University of Toronto. Dr. Ammendolia is an assistant professor in the Institute of Health Policy, Management and Evaluation, the Department of Surgery, and the Institute of Medical Sciences at the University of Toronto. In 2012, Dr. Ammendolia was the recipient of the Professorship in Spine Award from the Department of Surgery in the Faculty of Medicine. In 2015, he was awarded the Chiropractor of the Year Award from the Ontario Chiropractic Association, and in 2016, the Researcher of the Year Award from the Canadian Chiropractic Association. Dr. Ammendolia has been in clinical practice for over 30 years and now combines clinical practice and research in the area of non-operative treatment of mechanical, degenerative, and inflammatory spinal disorders with special interest in degenerative lumbar spinal stenosis. Dr. Ammendolia, it's an honor to have you on the Chiropractic Science podcast.
Well, pleasure to be here.
Great. Well, let's go ahead and usually I like to ask my guests how you became interested in becoming a chiropractor.
Well, it's likely an intersection of a number of different things, but the first thing was that I was quite an active athlete when I was young and very prone to injuries, and so often had to seek care for those injuries, and that was the first thing. And the second one was that I grew up in a family that was very non-interventionist, rarely took medication and seemed to try to get nature to look after things, and good diet and exercise. And my mother was I guess you could call her an early bone setter. She would often manipulate my back when I was young, when I was sort of stooping forward. She'd have me sitting down on the floor, and she'd be sitting in a chair with her knees up in my back, and I'd be crossing my arms over my chest, and she would grab my hands and pull backwards until I get an audible release down my spine. And she says, "Oh, that's good. Now you'll be straighter." And so that's the kind of family I grew up in, and combining with the injuries I had, I sought chiropractic care, and it sort of aligned with my philosophy of real low intervention and let nature take its course. And then I got interested and decided that's where I want to go in terms of career.
Yeah, very good. So have you been in practice ever since graduation from chiropractic college?
Yeah. I graduated 35 years and celebrated our 35th graduation ceremony this past June. So I've been practicing for 35 years, and I've been practicing every year since graduating 35 years ago. Even during my academic endeavors, I continued to practice at least one day a week while I was doing my PhD, a couple times a week when I was doing my master's. But other than that, I've been in full-time practice ever since.
Oh, that is terrific. If you don't mind, could you just tell us a little bit about your practice? Do you see special populations, or are you a general practitioner chiropractor? How would you describe it?
I run a specialty clinic at the hospital. So I'm the director of the Spinal Stenosis Program at Mount Sinai Hospital in Toronto. So I combined seeing patients. So about 3 days a week, we see patients in the clinic. I would say 60% of them are spinal stenosis, whether it be cervical spinal stenosis or lumbar, and lumbar being the most dominant. And then the rest of patients coming in with inflammatory back pain. I'm in a rheumatology department, and so we do see a lot of patients with rheumatological conditions, including ankylosing spondylitis and other spinal arthropathies. And I've developed a non-pharmacological approach to patients who have ankylosing spondylitis as well as spinal stenosis. So we have a number of patients who have those conditions. And then the rest of them are mechanical neck and back pain, degenerative neck and back pain that come into the clinic. And then that's the practice perspective. And then we also teach. So we have chiropractic residents from the Canadian Chiropractic College who come in on Mondays, and they're in with me 3 months on their rotation. And then on Fridays, we have medical residents. These are medical doctors who are pursuing a family practice specialty, and they'll spend 3 to 4 half days a week with me learning how to examine patients with neck and back pain, how to do differential diagnosis, how to come up with a treatment plan. Beyond using medication, they get to understand what chiropractors do and also non-pharmacological options for their patients, but primarily how to build up some skills on evaluation, particularly examining neck and back pain. And then we do the research. So that's what I like best about what I do. I combine clinical practice with research and training, and I also do lectures at the university. But what's really nice about what I do is everything sort of dovetails. What I see in clinical practice is what we do research on, and that's what we teach. In terms of my teachings are really around the things that I see in clinical practice, which are the things I do research on. So everything sort of joins together and integrates together, and that's what makes it so enjoyable.
Yeah, I really love that model. Terrific. So what was it that got you interested in pursuing a master's and a PhD in the first place?
Well, back in the 90s, the Canadian Chiropractic College was in communication with the university, York University, which is a local university here in Toronto, with the goal of affiliation. That is to say, the chiropractic school will move into the university environment, and that was exciting, at least from my perspective. And I had been in practice for about 15 years at the time, and I had been doing some teaching at the time, and I thought it would be a great for a chiropractor to be teaching chiropractors, and in order to be teaching in a university, you need to be credentialed, right? So I thought, well, I always like to pursue higher learning, and I was teaching anyway. I thought I'd go back and get my master's degree. Wasn't thinking PhD at the time, but at least master's degree, so at least I could go back in the university setting and be a professor to chiros in the university environment. The unfortunate thing is that agreement fell through and it never really ended up happening, but I continued to have a thirst for further education. I really enjoyed my master's in clinical epidemiology, which is really a science around looking at the evidence around the things that people do in terms of healthcare. In our case, it's what we do for back pain and neck pain, and what's the evidence supporting it, and can we find things to do more good than harm? And that was the essence of of the area of research that I was interested in. And so I got really turned on in terms of research and learning how to evaluate the evidence around treatments for back and neck pain, then started to publish papers, then started collaborating with people all over the world that was interested in doing the things that I was doing. And then I decided that I wanted to do my PhD just to gather more credentials and gather more knowledge in the area of neck and back pain in terms of the evidence and interventions and testing and all the things that we do in clinic but may not have the evidence for it. I wanted to pursue that. And so I went back and I did my PhD, again, trying to garner more knowledge and garner more credentials so I can continue to work in the university environment.
Perfect. Thanks for describing that. Now, you've published in some excellent journals, including Spine Journal, BMC Public Health, Clinical Journal of Pain, European Spine Journal, just to name a few. And today in this interview, we'll cover some of those papers, a few of them mostly focusing on your work dealing with the non-operative and chiropractic care for spinal stenosis. So what I'd like to get started with is hearing from you an overview about spinal stenosis, since we're going to be talking about it quite a bit today. So if we could start out with first, what is spinal stenosis?
Well, spinal stenosis really is an anatomical description referring to the narrowing of the spinal canals, both the central canal and the lateral recess canals. And basically, spinal stenosis is just an anatomical description without clinical information. Just because there is narrowing of the canal is really meaningless. Neurogenic claudication, on the other hand, is the clinical syndrome caused by spinal stenosis. And that is defined as buttock pain, either unilaterally or bilaterally, and or numbness, tingling, weakness, heaviness of the legs. That gets worse with standing and walking. The more you walk and the more you stand, the more the symptoms intensify. And these symptoms traditionally and characteristically get better when you stoop forward or you sit down. So that there's a dynamic nature to the condition. That is to say, posture changes the symptoms that patients experience. So again, spinal stenosis, it happens primarily as due to aging, and a lot of people have spinal stenosis on imaging and have no symptoms. And that's why I caution that, spinal stenosis is really an anatomical definition, and without clinical symptoms and knowing what the symptoms are, you really can't say anything about spinal stenosis unless you know what symptoms the patients are experiencing.
Got it. So if I hear you correctly, then some people with the exact same looking spinal canal on MRI, for example, may have two completely different symptom presentations. Is that true?
Absolutely. In fact, 30% of people over the age of 55 have moderate stenosis and have no symptoms. So that's a pretty large chunk. So if you're just looking at MRI and trying to make clinical decisions on an MRI, you're going to be going down the wrong path 30% of the cases, or many, or much more. So it's very, very dangerous to just base your treatment with just looking at an MRI. You really need to have both information at hand, the patient symptomatology and the MRI. And oftentimes you don't even need an MRI, because neurogenic claudication is a clinical diagnosis. You don't need an MRI for it. In fact, although most of my patients have MRIs in the clinic, and that's because the vast majority of patients referred to my clinic are referred to my clinic by specialists, rheumatologists, spine surgeons, neurosurgeons, physiatrists. So these patients have already been through the diagnostic workup, and they have MRIs. But for the most part, unless patients have red flags suggestive of serious disease like a cancer or infection, and patients are not having progressive neurological deficits like a drop foot, or they're not having cauda equina, you really don't need an MRI from a non-operative treatment perspective. You don't need to have an MRI to treat these patients, because you're really looking at these patients whether or not they have neurogenic claudication or not. And if they do, and they don't have any underlying red flags suggested of serious pathology, then you can pursue your treatment program without any worry in most cases.
Yeah, that's terrific. I'm really glad you mentioned that about the imaging, and that you don't need to do it all the time. It seems like we are too quick sometimes to want to get the imaging, and we want to.
Yeah, that's so classic, because when I have my medical residents in on Fridays, and then they're doing a workup on the patients, and the patients come in with the MRI, the first thing they'll want before they actually even ask questions and doing the patient interview, they want to look at the MRI. And I quickly take it away from them and say, you're going to look at this at the very last. Once you've done the history, once you've done the physical examination, then you come up with your diagnosis and your differential diagnosis, and then you go to the MRI. So I have my trainees look at the MRI last, not first, because it will prejudice their views, and oftentimes they'll be wrong.
Excellent. Excellent. Well, one of the areas, of course, that you're interested in is lumbar spinal stenosis, and you've created a boot camp program for lumbar spinal stenosis. And I first heard the evidence for this at DC 2017. I was in the room as you were talking about this study. What I'd like to do is have you go through this boot camp program, if you will, what the objectives of the boot camp were, what the methods were, and then if you can go through some of the results and what some of the takeaway points are, that would be terrific.
Okay, sure. So basically, we did a study, a case series, which means we looked at a series of patients, 49 to be exact, several years ago, who were enrolled in our boot camp program. And when we evaluated these patients after 6 weeks of their program, there were astonishing results in their patients' outcomes. And these outcomes were selected a priori. We were looking at the Oswestry back questionnaire. We were looking at the spinal stenosis questionnaire, which is a condition-specific questionnaire. We looked at leg pain and back pain. We looked at patient satisfaction. And what we found that in this kind of pilot study, we found that the patients were both statistically and clinically important. Outcomes occurred on all outcomes that we measured at the end of the 6 weeks. So that was kind of our first look at some evidence around the boot camp program. And then we decided that if we really wanted to get some higher level evidence, that we wanted to do a randomized controlled trial on the boot camp. So that's sort of the reason why we did the clinical trial, is that because we had some sort of preliminary evidence that it seemed to help patients in their pain, in their ability to walk, and their quality of life. So the boot camp program is a program, it's a 6-week program, and it's the aim of the program is really to improve walking ability, because walking limitation is the dominant limitation of these patients who have spinal stenosis. So they have difficulty walking. So we decided to make the primary outcome being walking ability. So the program is 6 weeks, and it combines manual therapy, and these are specific manual therapy techniques that are addressing the multitude of issues that are impacting people's ability to walk, and I'll get to that in a little bit more detail in a second. The second component is home-based exercises, and these are, again, condition-specific exercises. And then thirdly, there are self-management strategies, so what patients can do on their own to maximize their walking ability and reduce their risk of disability. And then we use a cognitive behavioral approach, and that is to change patients' attitudes and beliefs about their pain, change their expectations around what they expect for their treatment. And these four things combined make up the boot camp program. So as patients come in, they get their manual therapy, and the manual therapy is aimed at improving lumbar spine mobility. It's aimed on stretching muscles that impact the alignment. Remember that I mentioned to you that neurogenic claudication is a dynamic condition. The symptoms change relative to posture. So we know that by reducing the lumbar lordosis or by getting patients to improve the intersegmental flexion of the lumbar spine, that they actually increase the size of the canal and reduce symptoms. So in order for patients to do that on their own, they need to improve the strength of their core muscles, and particularly the muscles that cause intersegmental flexion. And they also need flexibility in the lumbar spine. So that's where the manual therapy comes in. But they also need to have flexibility in muscles that would normally cause increased lordosis, primarily the psoas muscles. Because these patients sit all day because they can't walk, they get shortening of the iliopsoas muscle and many of the other pelvic muscles. So we use techniques, manual therapy techniques, to lengthen the iliopsoas muscle, bring mobility to the lumbar spine. And also we do neuromobilization to improve the mobility of the spinal nerves that travel through the spinal canals. There are techniques that we use to improve spinal mobility in the lumbar spine to facilitate mobility of that lumbar spine, facilitate mobility of the lumbar nerves that travel to the legs, with ultimate goal of getting patients to get into a pelvic tilt position when they're walking and standing to improve their ability to walk by improving the blood flow to the nerves, because neurogenic claudication, in fact, is a neuroischemic problem. There's a lack of blood flow to the nerves when patients stand and patients walk, but that blood flow can be improved by changing the lordosis of the lumbar spine. So the program over the years came up with these series of manipulation techniques and manual therapy techniques, a series of different exercises that are aimed at the various things I just mentioned. And then also the self-management strategies. These patients can't walk, so we need to show patients how they can change that alignment when they're standing and they're walking by engaging their core muscles, by flattening the lordosis, and using that technique to walk and to stand. So the program is unique in that it's not just exercises that once or twice a day, but it's also taking those exercises that they learn to do and translating them into activities of daily living, when they're shaving, when they're brushing their teeth, when they're putting their makeup on, when they're walking, when they're standing at the checkout counter. These are the times they have symptoms in their legs. And by changing the alignment, by getting into a different postural alignment, that these symptoms can change and decrease and improve their ability to walk and stand.
Terrific. So in this study then, you just described the methods very well. What did you find in terms of the results, and how long specifically were they treated like that?
Yeah. So what we did was that we randomized 104 patients. Half of them got the Bootcamp program, so they came in twice a week for 6 weeks and got the multimodal treatment as I described, the manual therapy, the home-based exercises, the instruction on self-management strategies, the education about changing their behaviors around their pain. And they got that over a period of 6 weeks. But they also got something else. They got a video and a workbook. The workbook described all the exercises they need to do, described the education, and also outlined all the self-management strategies. And they also got a video, a DVD, that did the same thing. It sort of reinforced what they got one-on-one in the clinic in terms of exercise and self-management strategies. And they also got a pedometer. And with the pedometer, they were asked to check how far they can walk every week, once a week, and document that on their workbook. And this provided them with some positive reinforcement on how well they were doing. And so that workbook would come with them at each visit, and the chiropractor would document what exercises they have to do now, because the exercises would be cumulative. So they came in for the first visit, they got 2 exercises. The second visit, they got 2 more new ones that they added to the previous ones. And over the 6-week program, they got a total of 18 exercises they would learn to do, not only for the program, for the 6 weeks of the program, but for the rest of their lives. So that was an important component. Then that was compared to the control group, which got 1 visit with the chiropractor, and they too got the video, the workbook, and the pedometer, but they were told to learn the program on their own. So they didn't get any manual therapy, they didn't get any one-on-one, they got no one-on-one education, but got all the exercises, all the self-management strategies in a video format, in a workbook format, and asked them to follow through on the workbook and do it on their own. So that was the control group. So then what we did, our primary outcome was the self-paced walking test. So that is a test where patients are asked to walk independently without crutches or without a walker, and to walk as far as they can until they need to stop. And then we would record the distance that they can walk in that 30-minute period of time. So if patients were able to walk more than 30 minutes at baseline, then they were not eligible. These are patients who could not walk. So they have to be able to not walk for more than 30 minutes to be eligible. So the average distance that people could walk who were actually at the end of the day enrolled was around 300 meters. That was the average they were able to walk. So what we did was that we randomized them to the 2 groups, and then we had them come back at 8 weeks, 3 months, 6 months, and 12 months, and then we reevaluated their ability to walk, as well as also we did some self-report measures like the oswestry, also the spinal stenosis questionnaire, We also assessed their leg and back pain. We also assessed the SF-36, which is a series of different subscales on bodily pain, mental scores. So it's a series of there. And then we also measured a variety of different other outcomes like balance and falls and all this other outcomes. So we measured a series of outcomes. So the bottom line was that when we looked at the outcomes at 8 weeks, the patients that were enrolled into the Bootcamp program, the mean improvement in their walking ability after 6 weeks, so we measured their walking again at 8 weeks following the completion of their program, the mean improvement was an additional 500 meters or half a kilometer additional walking ability after the Bootcamp program. That compared to the control group of an additional 200 meters. So that's quite a compelling increase in their walking ability. So these patients were able to walk an additional half a kilometer after the Bootcamp compared to only 200 meters with the self-directed program. But even what's more compelling is that those results were sustained at 6 months and at 12 months. That's after the treatment was completed. So the treatment completed after 6 weeks, and patients were told to do the program for the rest of their lives, because this is something that there's no cure for spinal stenosis, that they have to learn to manage it on the rest of their lives. That we actually got behavioral change because the improvement at 6 months was 550 meters, and at 12 months it went up to 675 meters. So the actual benefit increased over time, even though the intervention theoretically had completed at 6 weeks. So we got both a compelling large magnitude of improvement, but the improvement was sustained even in the long term. And so these results were quite surprisingly positive for the Bootcamp program.
Yeah, that is really terrific. Now, just in case I missed it, you followed these people for up to a year time period. Was there a difference at a year between the group that got the manual therapy and the control group in the walking distance at that point?
Yes, there was. Yeah. So there was a significant difference both clinically and statistically at all follow-up points, where the Bootcamp program was superior to the control group at each follow-up point: 8 weeks, 3 months, 6 months, and 12 months. So to give you an example, the increased walking ability at 12 months, as I mentioned, was 675 meters of additional improvement compared to the control group of 201 meters. And so that difference was statistically significant and clinically significant as well. We also did another measure as our primary outcome, and that is the proportion of individuals who were at least 30% improved in their walking ability. And 30% is considered the minimal clinical important difference, or the important difference to patients. And so when we looked at the outcomes at 8 weeks, 85% of the patients who were in the Bootcamp program were at least 30% improved, and that dropped down to about 75% at 12 months. And that compares to about 60% in the control group at 8 weeks, and at 50% at 12 months. Again, with the comprehensive or the Bootcamp program being superior, both in the proportion of individuals reaching the minimal clinical important difference, and as well as in the distance walked, both at 8 weeks and 12 months.
Wow, that's really interesting. So now I have a few questions for you about that. First of all, with the manual therapy influencing the walking distance that much, and I'd like to say that I congratulate you for using that functional measure. I think that's really terrific, because that's where it really comes home for the patient, is in their daily activities. So thanks for doing that.
We wanted to include an objective measure of walking, which is lacking in other clinical trials. And so patients can't walk. And so you need to measure their ability to walk if you're really going to want to say at the end of the day that your program does help patients. And if you can help them walk, and that's what their main limitation is, then I think you're doing a good service, or a great service to patients.
Yeah, terrific. It's where the rubber meets the road, no pun intended.
Exactly, yeah.
So with that, a few things. One, how would you describe the manual therapy techniques that you used in the study? Like, did you use flexion distraction technique? Were you side posture adjusting? What kinds of techniques did you use?
Yeah, so we use all of that. I mean, the techniques by themselves are not really new to chiropractors, but when you put them all together, it sort of focuses on those techniques that are going to likely make a difference in patients' mobility in the lumbar spine. So that's we do use flexion distraction, although it's not a necessity. So we use flexion distraction on all patients. The actual manual therapy technique, and we've timed it many, many times because I do workshops all over the world on the Bootcamp program, and I've been timed many times. It takes me about 5.5 minutes to do the manual therapy component of the program. So our visits are roughly around 15 minutes, and of the 15 minutes, about 5 minutes is the manual therapy, and the rest is education and showing exercises. So back to the manual therapy. So we use flexion distraction. The reason why we use that because we're trying to improve the intersegmental flexion of the lumbar spine. At the end of the day, our theory is that if we can improve intersegmental flexion, then we can teach patients how to get their spines in a flexed position using the pelvic tilt. Their spine has to move. If the spine doesn't move, then they're not going to get the intersegmental flexion, which we do know through many, many studies increases the size of the canals. So side posture manipulation we use, and we use sort of a generalized approach, trying to move and try to mobilize each of the lumbar spine segments from the L1 all the way to the sacrum. So these patients are put into flexion, they're using side, and the goal is not necessarily getting cavitation, although it happens all the time. The goal is really to introduce mobility, particularly intersegmental mobility. And so flexion distraction helps you do that side posture manipulation, but it has to be done in a certain way. You cannot introduce extension when you're doing side posture manipulation. You have to introduce flexion. So the patient's knee has to be up into the chest. So there's subtleties. I mean, we say side posture manipulation, but we're very, very conscious on how that is actually procedure is done, because you can do side posture and you can make patients worse because you're going to introduce extension when you're doing forceful manipulation. So it is side posture, but you need to introduce flexion and not extension. Then we use a variety of different manual therapy techniques to stretch the iliopsoas muscles, to stretch the intersegmental muscles like the multifidus muscles. We stretch the piriformis muscle because the most common location for pain in these patient populations is in the buttock. And the reason for the most common location at the level of the spine is L4, L5, and the nerves that travel from L4, L5 supply the piriformis muscle, and that's why that muscle goes into spasm or becomes like a hot poker in these patients. And the symptoms are actually most commonly in the buttock due to spasm or hypertonicity of the iliopsoas, of the piriformis muscle. So techniques that we use help to stretch the piriformis muscle, help to stretch the hip flexors and iliopsoas muscles, and then there's some general mobilization techniques for the spinal nerve. So we use neuromobilization. There's a whole science around that, and there's various techniques you can use. I know Don Murphy uses the sitting one. I don't use the sitting one. I don't like the sitting one. I like the supine one. And patients use a strap over their leg and do neuromobilization techniques that are described in our workbook, in our videos, and show patients how they can do this on their own, but we also do it in the clinic as a manual therapy technique. So manual therapy techniques directed to the lumbar spine, manual therapy techniques directed to the soft tissues, particularly the muscles, manual therapy directed to the neural elements, because when you do a neuromobilization, you can get up to 2 centimeters of movement of the spinal nerves inside the canal, and that's been documented through research. And these are the techniques that we use in the clinic, and we use it all the time on all our patients with lumbar spinal stenosis who have difficulty walking.
Yeah, I love it. And I really appreciate the level of detail. I think that makes it explicitly clear. So thank you so much for going into that. Do you also use spinal traction, or I've heard it referred to as decompression? I'm not sure it's the appropriate term, but do you use those sort of techniques?
We don't use it, and there's no evidence around that decompression. We have a lot of patients A lot of patients ask us the question. I get lots of emails from doctors and specialists in my clinic asking about decompression for spinal stenosis, and I tell them the same thing. There's no evidence to support decompression for spinal stenosis.
Thank you for going through that. That's great. And what about the exercises? Can you give us I get the sense that you do exercises that are trying to encourage lumbar intersegmental flexion. What would those look like exactly?
Well, they're the classic ones that we all learn to do for our patients. They're knee to chest, knee to opposite chest, double knee to chest, and then there's other exercises they do to improve. It's like pelvic twist activity, knee to opposite chest activity, where they're on their backs and they're doing a variety of different techniques to get intersegmental flexion. So that's the normal ones. But what's unique about the program is that it's not just doing the exercises, but they know how they have to do it, but also how often they got to hold it, what the frequency is, how many times a day they have to do it. And what's unique about our program, again, we have a workbook that outlines very, very specifically what they have to do every day, what exercises, how often, and then how every week the exercises progress in terms of their intensity. And also they're on stationary bikes. Everybody's on a stationary bike because these patients are sedentary because they can't walk. And so they lose strength in their legs, not only because of the lack of nerve supply to the muscles, but also because they're deconditioned. They can't walk. So they're also gain weight because they're sitting all day and they can't walk, and their overall fitness decreases. So part of the program, a key component, is to get aerobic fitness. And because when they're on a stationary bike leaning forward in a flex position, they have no symptoms, we use a stationary bike as part of our program. So but it's very rigid. I mean, they're in there every week. They're told exactly how often they're on it, twice a day for their biking, and they start off with a very low intensity, and that's tailored to the individual's fitness level. But every week that intensity increases to a maximum of 30 minutes twice a day, and then after the 6 weeks, the program goes down to once a day in terms of their exercise program.
Okay, great. I know you have a boot camp training program for chiropractors, and I believe that's offered both via live seminar and online. Can you tell us about how a chiropractor can specifically get involved in and get that training from you?
Sure. So I do these workshops all over the world in terms of their day workshops. I'm doing 2 in Denmark right now. Denmark, I'm going in September doing 2 workshops in Denmark in September. I've got 2 workshops I'm going to be doing for the New Jersey Chiropractic Association in October. I'm doing 2 workshops there. So you can sign up through there. We do them right across Canada through our Ontario Chiropractic Association. You can also go on our website. There's some e-learning you can do. There are videos and workbooks on our website. It's spinemobility.com. Spine mobility being one word.com. The workbooks, videos, and e-learning is there, so you can go and learn how to do it online. Although it's not the best because you don't get the hands-on, where you do get that on the workshops. But, we train people remotely from different parts of the world who don't have access to workshops. And so we try to do at least the second best to get to know where how to do it through the videos and how to do the exercise through the videos. Although it's the second best, but it's better than not having the workshop available to you.
Yeah, absolutely. So if the chiropractor wanted to register for this online or live, they could just go to spinemobility.com and do that?
Spinemobility.com. Yeah, that's right. And the other way of doing it is getting your association to contact me or my association, the Ontario Chiropractic Association, and set up a workshop. And this is what we've been doing now. We've done them for the Zurich in Switzerland. They had their annual convention last year or 2 years ago, and I was invited to do the workshop there. That's what I'm doing for the New Jersey Chiropractic Association. I did that in Vancouver and then in St. John's and Ottawa, all over in Canada. And also I just got back from Cuba. I was invited in Cuba to do a workshop there. So I guess it's people that are interested that can get their association to inquire about getting a workshop at their convention, or even if they're interested, I could come down. If there's enough people that are interested in learning how to do the boot camp, then I could come down and train the chiropractors there.
Great. Well, I'll contact my state association, and I will also put a link to your website on the podcast too. So
that'll be great.
Yeah. So I'd like to talk about another couple of studies if we have time. The first one is from the Journal of the Canadian Chiropractic Association. This just came out this year, and it was further information about neurogenic claudication. It was about the patient perspective. Can you talk about that study a little bit?
Yeah, so that study was really wanting to learn more from the patient and how spinal stenosis impact their lives. So oftentimes it's from the doctor's perspective, and we see lots of papers written from what they see the patients are suffering, but we think it's best, if we're going to start measuring things that we think are important to patients, we need to ask patients what's important for what's important to them. And so we did a qualitative study and interviewed patients both from my clinic and also from Dr. Raj Rampasad, who is a spine surgeon here in Toronto, his patients. And so we had about 28 patients combined, and we interviewed them and asked them questions about, how does spinal stenosis impact your life? How did you find the treatment success? What things are really important in terms of treatments, and what are your expectations around treatment? And ultimately, how is it impacting your life? And so we were quite astonished by the results because we figured, we knew that pain was likely the most dominant symptom that patients experience, and we were right about that. And we knew that walking was the dominant limitation, because that's what they kept telling us, and so we were right about that. But what we didn't know a lot about was how emotionally patients were impacted by the condition. And the stories that patients were telling us were really heartbreaking, and that, some were even suicidal, and that the fact they were mentioning that they waited all those years waiting for retirement. And so now when they got to retirement age, they were looking forward to golfing twice a week, going traveling around the world, and playing with the grandchildren, going for leisurely walks. And basically they couldn't even walk across the street because they had symptoms in their legs. So they became quite distraught. They became frustrated because they tried all kinds of different treatments, medications, and weren't getting any better, and really felt their quality of life severely being impacted. And so we were quite taken aback about the emotional impact that this particular condition was having on these patients. And so we wrote about it, and so that doctors can pay attention to not only the physical elements that the condition presents with, but also the emotional and the psychological impact that it has. And so that's why our bootcamp program, the basic foundation is a cognitive behavioral approach where we deal with the emotional issues using a cognitive behavioral. You don't need to be a cognitive behavioral therapist to be able to use cognitive behavioral approaches in your clinic. We use it every day and probably not even know about it. But that's just showing empathy, showing concern, and also showing positive reinforcement, and also addressing the issues of with the patient, and showing that there is hope, because our data shows that patients can improve their walking significantly. Patients can reduce their pain. Our pain in our bootcamp program was reduced by 2.8 points on a scale of 0 to 10. That is highly clinically significant, and that was maintained at 12 months. So we do tell them your pain can come down, that you can. 85% of our patients are at least 30% improved at 8 weeks. And the vast majority of them, almost 3/4 of them, are maintained at 12 months. So there's the hope, for patients. So and then also mitigating expectations is really key to helping them reduce anxiety, where you don't tell the patient that you're going to eliminate their pain, but you tell them that your pain will come down, and then we're going to focus on their function. So their anxiety comes down, and their hope goes up, and they feel better about themselves. So what that study taught us was that you need to address the emotional component, and your interventions have to address it, as well as not only the physical but also the emotional and psychosocial. And that's what we try to do with our boot camp approach, is to address all the issues that are often not addressed. And then also in our outcomes, we also address them as well, because we start measuring things like depression. We measure things like anxiety levels, because these things matter to patients, and you should be measuring them not only in the clinic but also in research.
Yeah, those are excellent points. Now, if you were giving advice to a chiropractor as to what to measure for these psychological or psychosocial variables, is there an efficient way to do that? Do you just get it from the history and ask certain questions, or do you have some questionnaires that you particularly like, or certain questions?
So there are what we call yellow flags, and they're similar to the questions you ask with the start back tool. I don't know if your audience is familiar with that, but it's a tool that was developed at Keele University in the UK, and it was basically a tool that would help to stratify patients from low risk, medium, and high risk for ongoing disability. And patients with high disability are usually patients who have high psychosocial barriers to recovery. And these are usually, pain avoidance behaviors. So patients who have stenosis do display pain avoidance behavior. Why? Because they don't want to feel pain when they walk, and they will avoid walking because they know when they walk they feel pain. And they often associate pain with harm. And so patients will not walk even with a little bit of pain, thinking that they're causing their problem to become worse. So you get all that in the history. Now you can use a formalized questionnaire like the Start Back tool, but I think experienced clinicians can easily detect patients who are distraught about their condition, who have depressed moods, who display the yellow flags like pain avoidance behavior, like focusing on pain and not focusing on function. Patients who are sort of have an exaggerated kind of display with their pain. These patients tend to be hyperalgesic because a lot of them are on opioids, which make them hyperalgesic because long-term use of opioids but these patients oftentimes display a very hyperalgesic phenomena where patients have more pain when you examine them than other patients have, and their reaction to the pain oftentimes is not exaggerated, but is more prominent. So these are the kinds of yellow flags that we see when we do the history, and those are the ones you need to look out for.
Okay, very well said. Thank you so much for that. The last paper I'd like to briefly talk about is one that you did involving healthy and productive workers, and this was using intervention mapping to design a workplace health promotion and wellness program to improve presenteeism. And this came from BMC Public Health 2016. I wonder if you could guide us through that study.
Sure. That was a study with the research question was that can we improve the health of workers, because really what we've been finding due to the aging population, that presenteeism is on the rise. So what is presenteeism? Presenteeism refers to the working wounded, meaning that people are at work but they're not working to their potential because they have a health condition. And the most common could be back pain, which is the most common, and the other one is mental health, like depression. These are the most common. In fact, depression now is higher than musculoskeletal pain as the cause of presenteeism. So people are at work, but they suffer from depression and anxiety, and so they're not functioning to their capability, and their production goes down. In fact, the cost of presenteeism far exceeds the cost of absenteeism in the workplace. So people can be off work, but companies lose more money from people who are at work and not being productive more than the people that are off work and not even at the workplace. So that's how costly it is. So companies are really concerned about that, because what they're finding is their patients are aging, and they have more. And when you age, you have more and more health conditions, and each of those health conditions can impact their productivity at the workplace. So large companies, particularly large companies who have the dollars to be able to spend, are looking to implement health promotion programs in their workplace to reduce presenteeism. In other words, get patients being healthier at the workplace so they can produce. So our job for this study was to go into our workplace, and we went into this very large insurance company and to assist them on improving their health and wellness program using a technique called intervention mapping. And intervention mapping has been around for a long time, and it's a technique that's been used primarily in the public health arena. For example, helping, improving nutrition in schools, reducing smoking in the workplace, so these kind of public health issues at a community level is where it's community, usually done for community interventions. And so the workplace is like a community. So we felt that using this kind of technique would be appropriate. And it's basically a technique where we gather all the stakeholders involved in presenteeism. And stakeholders refer to the actual individual worker, his supervisor, the president of the company, the nurse, everyone who's involved who potentially can impact presenteeism is considered a stakeholder. And so there's a technique in intervention mapping where you design a program with the assistance of stakeholders. And so you get stakeholders who come around a table and discuss what are the barriers to presenteeism, what are the factors, who are the individuals impact. And then you start drawing these maps where you draw things that will help presenteeism and look at barriers. And then you go to the literature and the science to see how you can overcome these barriers. And then you train individuals how to overcome these barriers. The most classic would be culture in terms of being a barrier. And culture refers to the culture in a workplace. Is it a positive culture? Is it a negative culture? Do people like to go to work? Do people not like to go to work because they don't like the amount of stress that they got? They don't get acknowledged for their work. They don't feel their work is being important, and that comes back to culture. And so culture, for example, comes from the top down. So in part of the intervention mapping, you would identify that as being a barrier to getting people wanting to come to work and be productive and follow through on the recommendations of their healthcare provider, on exercise, on lifestyle management. Oftentimes there's barriers for people to do those things, and then we feel that the people at the top have to be examples and demonstrate examples on healthy lifestyle, on eating properly. You have to have proper nutrition in the workplace. You can't have, poor healthy habits at the cafeteria. So management has to come on board, not only to show as an example, but also change the culture in the company, so workers will feel that that what they're doing is going to be acknowledged, and that they're also doing things for themselves, but they want to do it because they want to help the company, as opposed to not just going there for a 9-to-5 job and going home and not concerned about anything to help the company in terms of improving their profits. So it's a really complex kind of intervention, but it's one that we use that was shown to be quite effective in coming up with a wellness program that could be helping patients make healthier decisions and ultimately being healthier at the workplace.
Yeah, terrific. Just out of curiosity, how long did the mapping and the intervention process last?
Well, it took a couple of years, because it was basically brainstorming meetings with the stakeholders. And when you're dealing with a company who's trying to make profits, and you're there trying to develop a program, trying to coordinate meetings. We had meetings twice a month for 2 years, and there were so many conflicts with scheduling that it sort of every meeting got delayed and then got canceled. And so it was because, I guess, in these workers had activities that they were responsible for getting done, and when they came to our meetings, that sort of interrupted the kind of work that they had to do. Even though the company was supportive in what we were doing, it was just trying to coordinate meetings, and that was the challenge. That intervention mapping is great, but it takes a long time to actually go through the process, and it's quite tedious. But that's what we decided to do. And retrospectively, I mean, it took forever to get done, but there are not very many other techniques that are better. Even though it's a long technique, it is an effective way of getting the job done.
Yeah, for sure. It seems like a thorough way to address the issues as well, not just a temporary quick fix. Right. So if you're going to change people's health, it can take a while, right?
Yeah, because you got to change behaviors. It comes down to changing behaviors, whether it's the Bootcamp program where you're changing behaviors for patients to do exercises and learn what they need to do for the rest of their lives, or it's changing behaviors in terms of diet, exercise, because that's, our most health conditions are ill health is due to lifestyle choices that you make, whether it be diet or not exercising. Some of it has to do with genetics, so we all know that, but most of it has to do with environmental and choices that we make. So it's really changing those, and those are not the most difficult thing is to change behaviors, but understanding the barriers and facilitators to behavioral change is the first step to getting things to change in the behavior. And the intervention mapping helped to sort of systematically look at facilitators, looks at barriers, and finding solutions to overcome them. And so that was the goal, the ultimate goal. But it's a tedious way of doing it. But really, when you have so many stakeholders and so many health conditions, because we're not looking at just one health condition, we're looking at the gamut of health conditions: musculoskeletal, mental health, the flu, diabetes, so the whole gamut of different health conditions that impact presenteeism. So it was very tedious. So that's why it took so long.
Yeah, well, that's awesome. Really enjoyed hearing about the process of it. Terrific. Now, a goal of the podcast series is to motivate and assist practitioners and students alike to pursue research careers in chiropractic science. Can you offer any advice to aspiring chiropractors who wish to become scientists?
I think it really comes down to passion, and I say that often because I have a lot of students who come up to me and say they want to do what I do, and because to become an academic and be a scientist, first of all, there's a lot of education that's required. So 2.5 years for a master's, and an additional 5 to 6 years as a PhD. So that's a lot of years, and there's always barriers and obstacles along the way. And the thing that gets you over these obstacles is the passion. The passion that you like doing what you're doing, and that gets you over them. So I think one has to have the passion to pursue a research career and a scientific career. And then the other advice is to sort of hone in on something that really turns you on. For me, spinal stenosis was something that, my dad had spinal stenosis. I've been in practice for a long time. I saw my patients who were in their middle years, and all of a sudden they became old and they couldn't walk. And so I was really intrigued about how that occurred and why that happened and what is it's going on. And I immersed myself in that condition. And I read everything possible, and then I started doing research and I started publishing, and now I'm the so-called expert in non-operative treatment for spinal stenosis. So having the passion, having the interest, and then finding an area where you are really intrigued by and really sort of, with me, I slept, and everything I did was around, I always would think about, well, how can I help these patients? What is it about that condition? So I was always asking questions and trying to find the answers, and I was thinking about it night and day. So that's the other aspect, the passion, but also finding an area where there's a niche somewhere where nobody knows how to treat that patient, or the evidence is quite sparse, and there's really not a lot of information. And then you go in there and you're the one that brings that information to life and get the information out there to people who can help others. So that's the way I did it, and that's the way I would recommend others do it, because it worked for me.
Perfect. Well, you can really tell that your passion is coming through, and I just appreciate you coming on the interview today and spending this time with us and educating all of us out here that are going to be listening to the podcast. So thanks again, and really appreciate you coming on.
Oh, you're very welcome. It was a pleasure.
Thank you. Thanks again for listening to this great interview with Dr. Carlo Ammendolia. I hope you've learned as much as I have about lumbar spinal stenosis and much more. Stay tuned for more episodes. If you have any suggestions or comments about the show, please let me know.